Welcome to the latest episode of Open Minds. We're absolutely delighted. Our guest, Craig and I's guest this week is Anne John, and Anne is a professor at Swansea University, and Anne will tell us a bit about, hopefully, about her career, her journey thus far. And Anne and I know each other pretty well. We've been involved in a number of different things together, and Anne is just fantastic. So welcome, Anne, to the podcast.
Well, thanks for that.
Welcome in.
Glad to be here.
Great. So maybe, Anne, let's just kick off. I was joking there about your, whatever you'll tell us about your career, but that's the reason we want to do a couple of things with the podcast today. Tell us a bit about you and your journey, because I think you bring really unique insights to the field of mental health science. But maybe maybe a bit on your journey, and then of course, as we move through that, we'll touch on to the work that you've been doing, the big data stuff that you've been doing. I mean, across, not just on suicide, and self-harm, I know your work, but more broadly than that. So let's just kick off, Anne. So tell us who you are. It's a sort of this is your life type thing. So who are you? You've started off, obviously, you've a medical background. So would you tell us a bit about that?
So I guess if I go right back, I would say that in school I was really interested in history and sociology, but I was a bit of an all-rounder. And so when it came to choosing A levels, I got quite seduced by the sort of helping people side of medicine. So then I went off to medical school, and through various routes, including a bit of psychiatry, I came to general practice. And I think general practice really brought all of those things together, because you're seeing people in their families and their wider contexts. But I sort of started feeling that in general practice, you were really seeing people when a lot of the things that affected their lives and affected their mental health had already been decided. And that's when I did my public health training. And during when you do public health, they sort of call it information for action. And that's where I learned all my sort of analysis skills, but they really come from a place of wanting to influence practice and policy. So then I sort of, without ever having planned it, took an academic job. So I sit between the NHS and a university, and that's a really good place to sort of work with people at the cutting edge of science, do science, but also work with people who can make a difference on the ground and policymakers.
Quite a lot there. So just rewind a bit then. So how long did you spend working in general practice, or was that just locum-based work, or was it just post-qualification, or what did you do there?
Predominantly, so I worked for about 3 years in one practice, and then sort of had children and made the decision to locum. But it gives you a real insight. So a lot of primary care work is mental health related, whether it's mental health problems in those with physical disorders, or physical disorders in those with mental health problems. And so you know, from children up to older people, you get a real exposure to how much mental health issues affect people's lives and choices and trajectories.
I agree. I mean, really important insights at that early stage in your clinical career, obviously before you moved into the academic career. So am I right in thinking your current title is you're Professor of Public Health and Psychiatry, is that right?
Yes.
And so, I mean, are there many joint chairs like that in the UK?
I think they're becoming increasingly common. But as many of us know, historically, mental health, both in services and research, has been underfunded. And then also in people's lives, there's been a lot of stigma. So I think there wasn't a room for a lot of us beforehand. Whereas I think now I think COVID, because lots of people who maybe led slightly more protected lives never experienced a lot of mental health challenges. I think it's really opened people's eyes to the importance of feeling mentally healthy and how much it affects you. So now I think it's increasing, but I don't think we were a very broad breed.
Yeah. No, I'm just saying, because in Glasgow, we've got a separate chair in psychiatry and a separate chair in public health. And I think, obviously, one of the things we've all learned moving forward in the field of mental health science is trying to break down those silos. And I think bringing the expertise from psychiatry, the expertise from public health, and bringing them together, for example, only two disciplines, but we're trying to do that much more broadly.
Couldn't agree with you more. So I work with electronic health records a lot. And in Wales, we're able to link primary care and secondary care health records. And I think that silo that happens in practice between people working in the community and people working in specialist services, you can also see that in some of the research and data that we do. So, lots of the things that we know about people with mental health problems are based on people who are in contact with hospital services and psychiatrists. And I think, being able to look at the primary care and the secondary care data and show how many people live with mental health problems in the community and never reach mental health services is really important.
Well, and indeed, if we look to the field that both you and I are passionate about in terms of suicide prevention, we know in the UK less than 30% of people who die by suicide have been in contact with mental health or clinical services or mental health clinicians in the 12 months before death. But what is it? Upwards of 80% will have been in contact with primary care. So really, that statistic alone highlights the importance of breaking down those silos as you described. So then moving on, and so how did you get involved in terms of suicide and self-harm work? I mean, was that just as a consequence of the mental health focus on psychiatry, or?
Everyone has experience of knowing someone who's died by suicide, but also for me, there was when I look at suicide prevention, I see it as the tip of the iceberg of almost everything else I'm interested in. We very much accept we need to take a public health approach. Lots of people who die by suicide are some of the most, excluded people in our society. Whether, some of that is things we'd recognise, like they've got a severe mental illness, but some of that is because they're excluded because they're unemployed or experiencing debt. And I think suicide prevention really shows how we have to have that breadth of practice.
Yeah, absolutely. And so, what you've touched on, obviously, maybe a focus of a lot of a theme which may run through this podcast today is that inequalities agenda and how we try to tackle mental health inequalities. And so that maybe brings me on then to thinking about, because you've been involved in a number of obviously big initiatives and actually in Wales itself, bringing together lots of different partners. And so could you tell us a bit about, first of all, the work that you've done, maybe if we start at the Welsh level, and then we'll maybe move beyond that, because obviously you've been involved in MQ funded or supported work, as well as obviously other national work. So if that's a way to go, could you maybe tell us about because I think we could probably learn a lot of lessons from what's happened in Wales and how you've been managed to bring together different partners and really be incredibly influential. So maybe could you tell us a bit about, first of all, your Welsh work?
So I guess for me, one of the things that working with data does is I never forget the people behind it. And I think some of that comes from having worked clinically. So I really know where the data comes from. But then because of the sort of analysis stuff that I've done in the past, I'm much less hands-on these days. You can see what's not there. So the people, we have this phrase where we go, what gets counted matters. And what you see with lots of excluded people experiencing inequalities is they're not visible in the data. And through using data, you're able to, and the results that you generate, we were able to pull together lots of interested parties. So practitioners are interested, policymakers are interested. And so through work, I chair what we call our National Advisory Group in Wales for suicide prevention. And I think because fundamentally I'm a generalist, I feel like, and that's not always a comfortable place to sit because you're never really, the expert.
What do you mean? What? Because I wouldn't have thought of you as a generalist. So, what do you mean by generalist?
So when I say generalist, I would say that from doing general practice, from being a medic who did a sociology degree, I've always seemed to sit across different boundaries in my life. And I don't know, sometimes I think, is that the lot of the child of immigrants? That you're used to sitting in places that you don't completely belong in and finding a language that works. And so I think through that and through the topic itself, one, I think suicide prevention, suicide and mental health have touched almost everyone. You're able to bring people together and try and speak, with an overarching aim that's common in a language that they understand, but with evidence. It's not opinion. You're using real world data from across different sectors to speak to everyone.
Yeah, no, that makes sense. That makes sense. So then go back to obviously the work you've done with in Wales in terms of leading the suicide prevention advisory group. So that led to the establishment then of, wasn't it a surveillance system?
Over time, a lot has happened through that group. So, we worked very closely with policy makers. We developed the strategy for Wales. I think one of the biggest differences we made was that originally there was very little ring-fence funding for suicide prevention. And we didn't really have people who were specifically assigned to work in that role. So we had lots of people who were working tirelessly, but often it was over and above other roles that they had. So it was a massive change when Welsh Government made that commitment. And then following that, when COVID happened, one of the, and you were part of this, Rory, we were all very concerned, and we were concerned because we thought that lots of the risk factors that we knew previously, people being isolated, people having financial difficulties, people being at home, potentially where home wasn't necessarily a safe place and they were going to be exposed to more domestic violence and abuse. We were concerned that suicide rates would increase. And, that got conflated with lots of anti-lockdown lobbying, and there was lots, I know you were involved as well. There was lots of unsubstantiated percentages of increases in suicide rates all over the internet. And I think it became important for us to know what was really happening. So I was involved in setting up the real-time suicide surveillance system in Wales, but then you, me, and a bunch of others with Jane Perkis from University of Melbourne set up the global suicide study, where we tried to access real-time data from around the world. And what we found was in that sort of first year and a half, in the vast majority of places that we had data for, suicide rates were stable or reduced. But I think the reason we could do the global suicide study so quickly was partly because we had those networks around the world in our field, and everyone, traditionally people aren't good at sharing their data, but we everyone got together, but also through MQ, we had the funded infrastructure through the Adolescent Mental Health Data Platform to house the data. And what that is what we call a trusted research environment. It's where you can house data and people can't get at it.
So lots going on there, Anne. Let's try and unpick some of that, right? So we'll come back to the suicide data in a second, but I'm just really curious I'm just thinking more broadly. You mentioned the adolescent platform, which obviously is supported by MQ. Can you maybe tell the listeners about that, what the aims of that are? What you've done with it thus far, and really why it's important.
So lots of people are doing lots of research in different electronic health records, and we never quite know if people are measuring the same things. So I could be saying I'm looking at anxiety in young people, but someone else might say the same thing. They'll use the same labels, but actually they're looking at stress, which can be a different thing. So there's something about people having the same understanding. We call it harmonization, and measuring the same outcomes. And so the Adolescent Mental Health Data Platform was about making data findable, so that, it used to be we'd do a project, and by the time we'd pulled all the data together and sorted it all out and cleaned it, we had about 3 months to do the analysis. Which is the important bit.
Exactly, yeah.
So what we were doing in the ADP was creating algorithms so people could do that cleaning, that definitions really quickly, so that they could spend most of their project doing the analysis in a data environment that's safe and secure, protects people's privacy, and that researchers who access the data have to go through ethical applications. They also have to go through safe researcher training. And then before anything comes out of the environment, it gets reviewed so that small numbers can't come out, so people aren't identifiable. So that sort of research infrastructure means that people can get to the bit that we're actually paid to do much faster.
So that's brilliant. So then 2 follow-ups on that. One is, so can anybody access that platform, assuming they go through a process?
Yeah. So there's so what happens is you, first of all, you contact the platform, and then you have what we call a scoping meeting. And that's where the feasibility of what you want to do is there. There are some costs involved. You have to be a safe researcher. So what that means is you have to have certain accreditations. And then, people from different universities can access the data. There are different safeguards for people from different settings.
Okay, that's really helpful. And then, just a wider question, and we think about the growth in big data, obviously globally, if I was a member of the public and I might be concerned, is my data going to be included? And if it is included, what safeguards are in place that I won't be identified and it is confidential and anonymous and so on?
So I guess there's lots of things that go on around this. There's lots of regulations, there's lots of safeguards that we all have to adhere to. And any system like the Sale Data Bank or ADP has certifications that relate to that relate to GDPR and various things that are set down in law and regulations. There's lots of work that's gone on about, opt-in, opt-out, and consent. And one of the projects that I work with MQ is called DATAMIND. And DATAMIND, there's an organisation, like an institute, a UK-wide institute called Health Data Research UK. And DATAMIND is a hub in there for mental health. And we have a really strong and active sort of patient lived experience public group. And these are we work with the public to develop one. So at the moment, we're developing what we're calling a data literacy course with an organisation called McPin. Because in order for people to have these conversations about, you know, how they want their data stored, whether they can be in or out, we all need to have some sort of common language to make those conversations meaningful. So we're developing that course. Myself, through some of my projects, you know, I remember going to MQ's youth advisory group, and I jumped straight into, you know, what are we going to do? What's the data? How are we going to link it? That's the exciting stuff. And they wanted to know exactly how we linked it. They wanted to know the linkage procedures. And that hadn't even crossed my mind that people would be interested in that. And so I think what that taught me at a very early stage in this sort of data career is that we constantly need to work with people to understand what they're happy with. And that's happening at all sorts of levels.
Have you found that people are fearful to share their data?
It's nuanced. So we recently did a big survey with young people, and their views weren't different really from most people. So if data is anonymized, which the data I work with is anonymized, if it's going to be used, if the analysis is going to be used to improve our understanding or management of people with mental health problems, generally people are very happy for it to be shared with people in the NHS and researchers with all the appropriate safeguards. So people are very much behind that. Where things get trickier is where it's being shared with industry or potentially going to be used for profit. And that's an area that one of the things we're doing in DATAMIND is we've got these two parts of DATAMIND. We've got a large group of people that we're talking with who are taking part in every single part of everything that happens in DATAMIND. But we've also got what we call an industry forum. And what we want to do eventually is bring those two groups together to develop standards for what's acceptable, what isn't, what are the tensions, where are the limits around working with industry. So I think you can't not recognise that exists. But for researchers in the NHS, where work is to help understand and manage mental health problems, people are very positive about the use of their data.
And can you retrospectively remove your data?
It depends on what research is being done. So there are discussions and systems being developed about routinely collected data. That's harder. Where you've consented, then absolutely.
Yeah. Okay.
So at the moment, that it really depends on the study. One of the things that I found really interesting in some of the work that we've done, we did some work on cyberbullying and bullying and self-harm. And one of the things we found was that for lots of other researchers, because social media data, a lot of it is like freely accessible, some researchers assumed that young people in particular were happy for it to be used. When we did that survey about use of data, in actual fact, young people felt more strongly about their social media data being used than they're routinely collected.
As in more strongly against it being used.
Well, much more that they wanted it used with consent.
Okay, yeah.
It's understandable because there's so many images in that data that they were really struggling with how it could be properly anonymized.
Yeah, and I suppose the other bit is that what the social media data highlights is that we've all, usually unbeknownst to us, we've all signed up to data sharing agreements when we've joined these apps that we've never properly read, probably, and that include those obviously data sharing agreements. But I suppose it is a really difficult area, and something I think which is so fast in its evolution now in terms of the legal requirements as well.
So when I was talking about that work with industry and the public and patients, those are the sorts of things that we need to explore. Because if we're all accepting that nobody's reading the thing of like, what are you signing up to, then in our world, the onus would be on us to make it more, people be more engaged with it, wouldn't it? I think there's still lots of work to do, but generally people see the benefit.
Yeah, but I suppose there's always strikes me as a wider point, and I don't mean this specifically to do with social media data, but in terms of the obviously informed consent is what you're getting at. And obviously all the changes over the last 15 or 20 years in terms of requirements, rightly, on investigators to ensure that the information is provided in patient information sheets or whatever it is. But I mean, some cases, and certainly some of the feedback we've gotten, you must have had the same, is there's so much information now required in some traditional participant information sheets now that it's impossible for people to properly understand it. And I do think that's a challenge between, yes, in one level, all the boxes are ticked in that all this information about every which way the data will be used. But actually, I dare say if you did, after somebody completed and faulty read the form, the information sheet, and you asked them, what did it actually say? I think you might get a very quiet response.
Absolutely agree with you. I think it's all of the things we're talking about are about being proportionate, aren't they?
Yeah.
So like lots of consent forms, not just in data studies, are so long now. I could barely read it.
Yeah.
And then, sometimes there are barriers to accessing data that people have consented to being used for research because it's hidden behind so many protective walls. And that means that the research gets quite delayed.
Mm-hmm. Yeah.
So, Sally McManus has got a brilliant slide showing how much the 2007 APMS got used and how much the 2014 one got used because of all the different permissions. So there's
just for the purpose of the listener though. So Sally McManus works for NatSen, and NatSen organize, if they don't, I don't know, well, organize certainly or curate the semi-regular adult psychiatric morbidity survey, just for those who are unfamiliar with that. Yeah, but you're right in terms of it was so much more difficult to access this time.
So I think what all of these things say to me in a constantly moving feast where data is concerned about what's out there, what we can access, how we can analyze it even, is that constant dialogue between regulators, policymakers, practitioners, researchers, public, and the patients needs to happen continuously.
Yeah, no, absolutely. Just to sort of move things on a bit, and a couple of other questions on sort of the data science and the big data challenges is I often wonder about the quality of mental health data that is routinely recorded, and similarly with physical health data. But I just know that in Scotland, for example, when we record our self-harm data, hospital admissions, there's a lot of challenges with doing that. So could you tell us a bit about, in your experiences, of how we find that balance of ensuring data quality but making sure it isn't, you don't have to wait 10 years for it and so on. So how do you go about that in Wales?
With lots of checks. So I'm a great believer in people using, doing lots of checks on their data, doing lots of checks on their findings compared to other findings. Doing those basic skills when you look at a data set I think you need to do in routinely collected data, absolutely. I think it's understanding where it's come from. This is data that hasn't been collected for research. This is healthcare professionals going about their day-to-day work, managing and treating people, in our field in crisis. And we're fussing because they didn't put the right code in. I remember doing all that, and I literally didn't care what I put down.
You didn't say that at the time, I bet you.
So what that shows us is there's also an element of us making sure that people understand why it's important. So 15 years ago, I never filled out the ethnicity questions. I always said prefer not to say, or just ignored it. And that was partly because subconsciously I must have realized that, saying that you came from an ethnic background was often a disadvantage in life. And there's lots of evidence that shows that.
Mm-hmm.
Now I fill it in studiously, because you realize that unless it goes back to that, if things don't get counted, you can't highlight need, you can't highlight discrepancies. So I think there's an element of training of people who are doing that routinely collected data input of why it matters. But I think we do have to have an understanding of the pressures in services.
I mean, when you've got whatever waiting list targets and waiting time targets, it is challenging. And I suppose if you're on the ground so-called jobbing clinician, I mean, what's incentive for you to do that when you have a long waiting list at your door, so to speak? Okay, no, that's really helpful. Just thanks for that. So maybe just move on a couple of other questions before we sort of bring it to a close. Maybe could you tell us a bit about a project you're working on now, and because I know you've been doing some work on predicting early mortality or premature mortality in the context of multimorbidity or mental illness, or do you want to tell us about that work? And I know it's been published in Schizophrenia Research.
We basically did work where we linked data from general practice and data from mental health services and hospital services, and we looked at why. So people with severe mental illness, so by that I mean sort of schizophrenia and bipolar disorder, and they die 10 to 15 years before the general population. Now, to me, that's a huge health injustice. And we really need to understand why. And there might be biological reasons for that. Mm-hmm. Because of my background, I tend towards social reasons for that. So what we did was we looked at what people were dying from. And what we found was that generally people with those disorders die from the same things as the rest of us. So 2/3 of the reasons were, heart disease, respiratory disease like pneumonia and things, diabetes, cardiometabolic things, all of that.
Yeah.
But they were 2 or 3 times more likely to die of those things than people without those illnesses. They were between 12 and 16 times more likely to die by suicide or die from what we know as sort of unknown causes. And many unknown causes are suicide or heart attacks. And I guess what that highlights for you is, one, a huge gap, so a huge inequality, but also the places that we need to manage things.
Mm-hmm.
Is it that part of the reason people with severe mental illness die more often from, things like pneumonia, is it because they present late? That gives us a real opportunity for prevention.
So why do you think they present late? What's the explanation for that?
Well, because it's well recorded that people with mental health problems have, our services aren't really set up for people with mental health services. If you've got to call and make an appointment before 8:30, that's very challenging But I find that challenging, let alone
Yeah.
if I had a severe mental illness and was unwell. So we need to design our services more around those people. It also shows that in suicide prevention, those with severe mental illness, we really need a focus on that. And we do have that. You know, we've got the National Confidential Inquiry and looking at those pathways. So we know that many people who take their own lives with severe mental illness, it follows an admission. You know, it's quite soon after an admission. I think about a third of those who die. So what this sort of work does is it really pinpoints where we can make a difference.
Yeah.
And because it's real world data, I think it speaks to policymakers and commissioners much more strongly than what we call discovery science, you know, much more the bench stuff.
Yeah, yeah. But then, okay, so I'll challenge you then, Anne, since you've just said this sort of research speaks more to policymakers. Okay, so I'm a policymaker, and I want to tackle the inequalities agenda, the health inequalities. Give me one or two things. What are my number two priorities? What should I do?
I think there's the global stuff of, you know, you can have active labour markets, you can have universal basic income, you can have fair benefits, you know, pulling people out of poverty, the risk factors that are associated with all of those things. Mm-hmm. You can have treatment, you can have services that are integrated. Understand that, and by services, I don't just mean primary and secondary care, and, you know, making sure liaison services work in secondary care and the community, but also within our schools, people having, you know, enrich from mental health services in the same way that, like 15 years ago, I was involved in enrich into prisons of secondary mental health care services. So I think there's all the work around service and access. And then, as well as all the sort of tablet treatments, I think we need to get better at things like social prescribing, you know, addressing loneliness in our communities. One of the reasons we think suicide rates were stable or reduced in the early part of the pandemic is about social cohesion and communities coming together. And I think, you know, that may not be the only reason, but I think there are things there that we can learn from and use in the future to protect people with mental health problems.
No, great. Really clear calls to action, really, and things. But what's interesting about some of what you said, it's stuff that used to be in place, but we stopped doing, and through austerity, and now obviously, as we both, I think, of the three of us would agree, really concerning time now, obviously, with what's about to happen globally and in terms of the cost of living crisis and so on as we move forward. So a really challenging time. And before we let you go, just a couple of quick questions, which would be really great. One is, well, how do you look after your own mental health?
So during COVID, I was doing lots of government advice, like SAGE and everything. And I literally think I sat down at my desk for 2 years. And I think I was clicking when I stood up. And so I think exercise is really important. So I do yoga and I do like a gym thing. And I walk my dog a lot.
A gym thing or a gin thing?
Gym. I also do a gym thing. But that might be less appropriate. And then I walk my dog a lot and I love walking in woods. And then I think family and friends, you know, none of that stuff I think is rocket science. We all know we should do it, but then pressures of life stop us doing it. But I think that coming, you know, that change for me, it's really shown me how important it is to protect those things and how I think you stay more in your life and connected, but also more productive in work.
Yeah.
If you make sure that you're doing those things.
So no, thanks for that, Anne. So one last thing in which we try and ask all of our guests is, is the thinking back to your younger years. So what advice would you give your 16-year-old self? And it can be on anything. It doesn't have to be mental health. It can be any advice at all.
I guess not to underestimate myself. I think when you're young, you don't always have an idea of everything that's possible. And so that's what I would say to myself. And that's what I would like us to do for young people in schools.
Don't think anybody suggested that one before yet so far in the podcast. I think it's a really good one about not underestimating yourself and trying to then, what else can we do in schools or society to, I suppose, widen the horizons or the aspirations of our young people.
Yeah.
And obviously, any listener want to check Anne out in her work that she does at Swansea University. It's on the website, and then there's obviously access, I assume, to the adolescent platform information on that, and the broader DATAMIND stuff, and the suicide monitoring or surveillance system, and all that's available online. So there's lots of great resources. So Anne, thanks a million for all the work that you do, and all the work you do for MQ in particular, as well as the broader work on suicide, self-harm and mental health. So thanks a million on behalf of Craig and I for joining us today.
Thank you. Thanks for having me.
Thanks.